Today, we've got Stavros Tsipas, health economist of the American Medical Association. And before we get going, can't do anything without appeasing the lawyers. So, would you like to throw out the obligatory disclaimer, Stavros?
Sure. Yeah, thanks, Andy. Yeah, I just wanted to say that, I'm just making these comments in my personal capacity and, not representative of the views of the American Medical Association. So thanks. But thanks for having me on. Really excited.
But they should be the views of the American Medical Association. Those
Oh,
were those were my words, not Stavros's.
yeah.
Okay, so let's talk a little bit about your background. How did a nice boy like you become a health
Mhm.
economist?
Oh, geez. Yeah. Well, I tried to get into economics. I found it very interesting. Started from a psychology background, realized, there's not much of a future in a psych degree, kind of unaware college kid. But transition to economics, found it really interesting. Found the idea that you could, kind of predict human behavior, or at least parts of it, really appealing. I like the math part of it, rigorous, logical. So I found that very interesting. So kind of not, I don't know if that's your traditional or not traditional background. I didn't have any, real interest in business or, I'm just not, I just don't have that gene, I guess. But uh, yeah, I just found it very interesting as a subject matter. And just the way it helps explain so many different phenomena.
Okay. Now, why health economics in particular? How did that journey start?
Well, yeah, health economics is really interesting. One of the things, I just have a personal interest in health, your personal health. I found that was interesting, but there's a lot of work around smoking cessation that I found interesting. My dad was a smoker at a time, he passed away since, but I was just like, why, why do people smoke? Growing up as a child, in a house with a smoker, I was like, this is horrible. I don't like this. How could we like prevent, future kids from, having to deal with something like that? So I found kind of working with smoking cessation to be very interesting. And then as I kind of progressed in health economics, just the size of the healthcare industry in the United States makes it very important. And there's just very there's three separate entities, right? There's the patient, there's the provider, and then there's the insurer, and they each have their own separate incentives, their own separate goals. I mean, they all want to see the patient get better, but to what extent are they willing to pay for it? To what extent are each of those willing to do things for that? The patient wants things that the insurer doesn't want to pay for. The insurer wants to pay things that the patient may not want. The doctor wants to do procedures that maybe the patient or the insurer don't want. So, how do you reconcile all those three groups is, a really interesting challenge as well. So I found that very interesting as well.
Yes, it sounds like a fascinating three-dimensional chess game.
Yeah.
Let's let's dig into your work on smoking cessation in particular,
Yeah.
because that's one of the uh, few true public health victories in the past half century. So, what were the levers to influence smoking behavior, and what are some of the other insights that you got from your work with smoking cessation?
Sure. Yeah. So kind of one of the things they determined was that smokers develop the habit as youth, and once it's sort of you know pre-adult, the brain's still developing. They think it's a good idea. They start smoking. It looks cool. I don't know, on TV or on the movies, and they want to try it. Or there's peer pressure. So kids develop smoking, kind of when their brains aren't fully formed, signing up for a lifetime of this bad habit. And one of the things that researchers realized was that if you could, stop that chain from starting, or stop that process from starting as a child or as a young adult, you could prevent smoking for the rest of the lifetime. There's not many 45-year-olds who just suddenly take up smoking, right? It's just it might happen, but it's kind of rare. So it's a younger thing. So one of the things that really helped was youth ID laws. Trying to take away cigarette vending machines in locations. Those things were around. I remember seeing them as a kid. Or you could, or dads would send their kids to the corner store and say, "Could you pick me up a pack of cigarettes?" And that was, that happened. So it wasn't unheard of. Then there's also clean indoor air laws really helped. Trying to stigmatize smoking, making it difficult to smoke in more and more places. So that really helped. And then, of course, increased excise taxes on cigarettes. So as you kind of increase the price of cigarettes, it becomes more expensive for people to do that, and kind of those all combined, really really helped decrease smoking. So now in the smoking literature, there's smoking, cigarettes, and now there's e-cigarettes and vaping, and having a parent to a teenager, listening to the teenagers in the car, taking them to and from places, the normalization of marijuana use. It sound I'm in Illinois. It's legal here to just smoke marijuana. So in my day, marijuana was like the big boogeyman. Like, oh, that
Uh,
that guy's smoking weed. Oh my goodness, if a teenager was smoking weed, it was he was like, oh man, that's a druggie. Whereas now, the teens are like, oh yeah, I have a vape pen with THC, and I'm like, what is going on? So we've
Out of the frying pan and into the fire. We
yeah,
health we conquered one health crisis, and now we conjured up another one out of the ether with vaping and THC. So
yeah. So I'm just trying to, just yeah, victory.
uh,
It's but yeah, so just
so
trying to steer my kid away from it, but there's still dangers abound. Yep.
So for those of you at home keeping score, it looks like we're 1-1. So we lost the nicotine war. We won the nicotine war, and now we're losing the vaping and THC war. So
Yeah.
the next thing I'd like to dive into is your early work in the insurance industry. Your first
Mhm.
your first job out of graduate school.
Yeah. Yeah. So I started working in employee benefits consulting, helping large self-insured employers determine kind of what's the best healthcare plan for their population. So it was very interesting work. My role was more on spending and utilization around their pharmaceutical products, the prescription drugs, and are they getting a good deal for this? Is this a good vendor? And just offering some results on those insurance products.
So what are some of the insights, the takeaways from how well the private insurance, how well the employer sponsored insurance market is working or not working?
Well, it's there. It's set up as a benefit for employees, right? So this is supposed to be helping employees, and it's but from the employer's perspective, it comes out as a cost, right? This is just in pure economics terms, this is salary, this is compensation that you're taking in the form of health insurance benefits rather than salary. So the employer is trying to minimize the spend on this benefit as much as they can, while still providing something of value to the employee. Where the problem comes in is that the employee's health behavior is for especially for self-insured plans determines the amount of spending that the employer has to lay out. So if you have a relatively unhealthy population, the health insurance spend is going to be larger than if you have a healthier population. So there's some, programs, employee wellness programs, trying to help the employees uh, become healthier. Kind of improve, modifiable risk factors, hypertension, blood pressure, A1Cs, cholesterol levels, get screenings, things like that, and those. kind of work, but it's very difficult to, there's the worried well who kind of, are well, but kind of consume healthcare more than the other might. And then there's the group that doesn't care, never goes to the doctor, will never, take a step, towards that. And then you have this small marginal group where some of those programs might be effective, might not, but
So so if I'm hearing you right, it sounds like we might be overspending on 2 fronts, the worried well, who they're
yeah.
healthy, but they're nonetheless getting a bunch of health care that they don't necessarily need, and then the unhealthy who aren't, taking care of themselves and might be over-consuming health care because of their poor lifestyle choices. Is that an accurate assessment?
Yeah, the second group, they'll have all of their healthcare expenditures in one big bunch as either a heart attack or a stroke or some other unfortunate event. And I don't know how you want to phrase it, the unfortunate or fortunate, however, depending on your perspective, those things happen at a time when the employee is no longer an employee, right? I mean, you're past the working age a lot of times. Those things are more prevalent in older populations over 65. So that's the federal government problem, Medicare. So if you could just keep the person healthy enough to work and not have a heart attack or a stroke or, avoid presenteeism. Presenteeism is that you're ill, but you're still showing up on the job. You're healthy enough to get the job done. Yeah, that's in many ways that's the goal of corporate health insurance plans. Though there are efforts to actually improve the health of their population, the levers they have available to them are somewhat limited because it's a benefit. This is you're supposed to be helping this person, and some people just don't want the help.
Okay. So it, sounds like, unlike smoking cessation, we don't really have much carrots and sticks, many, levers to influence the outcomes,
Yeah.
and the few levers we had, so we mentioned, corporate wellness programs, we mentioned preventative healthcare, getting your metrics checked,
Mhm.
blood work, etcetera. I gotta tell you, Stavros, you shouldn't play poker, you don't have much of a poker face. You gave me when I mentioned corporate wellness programs and preventative medicine, uh, you did not seem very keen on them as cost reduction strategies or health improvement strategies, so, uh,
Yeah.
how how pessimistic are you?
Well, there've been some studies with randomized, interventions to see, what the effectiveness is, and if it does anything, it's small. And like I said, it's because you can't like with the cigarettes, right? We could tax them. You could, you have to pay, $10 more for each pack. You can't do that to an employee, right? They'll quit. Like I'm getting taxed for eating donuts or something. Like they're just it's just the like your employer now becomes the controller of your health behaviors. It's just it becomes a very strange dynamic. So yeah, there's very few sticks. I think after the ACA they could the one of the things was that they could assess smokers a higher premium, but as we just talked about, there's less and less smokers than there was in the past, so that's becoming less and less of a effective lever. So a lot of it is carrots, and it's who wants a carrot when you can have a donut? So the carrot doesn't have the effectiveness that we would be hoping, and it's the size of the benefit that you'd have to provide to kind of compel somebody to improve their health would kind of blow the budget of the employer, right? Because this is again an expense they're trying to minimize, provide good health care to their employees, but they don't want to spend I mean, they're already, even with the current levels of healthcare spending, it's something like, $20,000, $30,000 for a health benefit, health insurance for a family in the US. So it's already a substantial amount of money. And, if you have some employees that are not, say, very productive, like these, companies that might offer benefits to lower wage workers. A substantial proportion of their compensation is in the form of health insurance rather than cash. And, how does the employee feel about that? And, this is kind of one of the big discussions, around ACA was, once employees could see how much of their compensation was coming in the form of health insurance rather than cash, would there be kind of this pressure from employees to, move some of that spending into cash, improve health behaviors, lower costs, lower spending, that whole thing. But it doesn't seem like it's had as big of an impact as people were hoping at the time.
Let's shift gears, talk a little bit about issue you touched on with the private health insurance market.
Mhm.
One of the things that came up in our discussions, which is I it's I'd never thought of it before, but it seems obvious when once you know the adverse selection that's going on in the private health insurance market, because people, pretty much everyone who's able to, is getting their health insurance through their employer.
Mhm.
So the population that's in the private healthcare market, whether it's Affordable Care Act or other,
Mhm.
kind of by definition, they're the ones who aren't working. So what implications does that have in itself for the private health insurance market?
Yeah, yeah. So that was kind of one of the big topics when the ACA was being set up was, the fact that you have to be somewhat healthy to be employable, right? And so if you're not healthy enough to work, you're sort of boxed out of the health insurance space, or the dominant health insurance space. So, and now what if you lose your job, but you're healthy enough to work, but you're unable to get health insurance, right? So you have these two types of people that are, outside of the employer health market, whereas, you're unemployable because you're so sick, or you're employable, but you just happen to not have health insurance at the time. So, these two populations, you can't necessarily differentiate them, a priori. You don't have like a mark, to say, hey, this person is this person's that. When you go to apply for health insurance benefits, you just show up, right? So, and you come as you are. So, yeah, that was kind of one of the things that, prompted a lot of these state healthcare plans as a way to address these adverse selection effects, with subsidies from the government to somewhat offset these added costs. My understanding is these insurance plans still aren't that great. They're high deductible plans. They have large premiums to them. They are, they kind of prevent, total financial destitution should something happen, but they're not cheap, and they're not, they don't provide the same level of benefit that, an employer sponsored plan would have. So yeah, it's an issue. I don't know how it's going to be resolved. It's just fundamental to the way the market is set up. If we,
Sure.
totally
So
read everything, but yeah, that's a huge, huge project.
so we have some adverse selection going on by the time somebody shows up for Affordable Care Act coverage. Like you like you said, it's kind of
Yeah.
like a bar or disco. You show up, you pay your cover fee,
Mhm.
you get your insurance.
Yeah.
There's not a lot of ways we can price risk it for that adverse selection issue.
Yeah.
What about after they've signed up? Is there We talked about some of the issues with the employer provided healthcare. How are we pricing or mispricing risk in the private insurance market?
So yeah, at least, for the Affordable Care Act plans, I think it's, you're looking at age and sex groups. The most of the health insurance a lot of times is a wealth transfer from the young and healthy to the older and sicker. And so, the younger you are, the more you pay because you're not going to be using that much health benefits. And especially men, women can also be in this program, but if you're lower income and a woman, you get pregnant, you're eligible for state Medicaid. So that also kind of changes the risk pool. So there's different programs for different populations based on their characteristics and income. So it's hard to get one single number because that population changes year to year and condition to condition. But for the most part, that most states have expanded Medicaid for their lower income populations now. So there's that. So you kind of have the really low income population that's in Medicaid. You have everybody who has a job that's in in the employer market, and then you have this like middle group that can be anywhere from lower income to and they're unemployable for whatever reason, or they're just whatever is going on with them, to somebody who has high income earning potential but just somehow doesn't have a job right now, and they're in that government subsidized market. And it's just like you can't necessarily differentiate pricing on that, so you have to have this wide band to cover. That's why a lot of people don't like the coverage, because it's trying to cover this whole big group, right? I mean, if you were you know, just pricing any product, right? If it's, this product is for, you know, pregnant women, right? The age demographic, the age, the sex demographic, salient characteristic about them, you could price it better than,
Yeah,
you could.
absolutely. Well, when I go to get auto insurance, they
Right.
ask you if I've ever had a DUI, right?
Yeah, 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 exactly. Right.
The basic questions like that. So let's talk about some international perspectives, because some countries have uh, proffered some solutions to this problem. Talk about the Singaporean model.
Oh, sure. So yeah, yeah, yeah. So I like Singapore. So it seems like it's a really well-run country. I haven't visited, but yeah. So I mean, they just have a very structured government plan. Everyone pays into it. Everyone kind of has their health insurance through the government. The what's interesting is that the services that they provide sort of differ from the way that we provide services. So one big thing is, say, private hospital rooms, right? I think most of the Singaporean plans have um, you don't have a private room if you go to the hospital. Whereas, the US, you have a private room. Should, you have a surgery and you're recovering after surgery or something happens, there's private rooms. So it's, they've kind of had this insurance program, and they've built out their healthcare infrastructure based on that insurance program. We've had a different insurance program, based on individual coverage, this employer market, and we've built out our healthcare infrastructure to support that. So we have, if we did want to change to like this, government run program, our healthcare delivery infrastructure, like the literal buildings that we are getting our care in, will have to change, right? And that's just these are costs that aren't really thought about or talked about often when we think about, oh, let's nationalize healthcare, or let's get like a government run program or something like that. That we would really have to change the way we kind of deliver care in the country as well. So it's not just, and I'm not, I think people sometimes think that they could, have their health care and pay less for it too, but I don't think it would work that way if you changed it to, say it's like a Singaporean system where, everyone contributes to a similar system. And, if you wanted something extra, you paid extra. It's a radical difference than
That's a very provocative statement, Stavros. So what you're talking about is basically path dependence. We built the entire infrastructure we built around healthcare is built for our current system of expensive, largely employer provided healthcare. And if we wanted to extricate ourselves from that morass, we would have to fundamentally rebuild healthcare from the ground up, including hospital and down to hospitals and single bed hospital rooms.
yes. Yeah. Yeah,
Okay.
Here's like a personal anecdote. I had a friend whose father got sick. Her dad was in Spain, and he was in his like 80s, 90s. And, she was a medical professional, and she was, very upset. She's like, oh, can we get, ICU care for my dad? Can we, get all of this, intensive therapy for him? And they're like, we don't do that in our system. You're past a certain age, you have, they have cost effectiveness studies that they do that, in other countries, based on qualities, or we don't I don't know if you want to get into all that, but
The dreaded death panel.
yeah, I mean, it's not sure, call it a death, whatever you want to call it, but yeah, at some point, there's costs and benefits, and there's only a certain amount of budget, and you spend as much of the budget on the highest return stuff as you can, and on down the line. But yeah, our healthcare system is set up that this is a benefit that Medicare pays for, so we'll pay for it. And, whether or not that meets some cost benefit standard, that flies out the window. We don't have cost benefit standards in our system. Other systems, say like national, NHS in the UK, they have a panel set up to lay this all out, right? I mean, you go to these international pharmacoeconomics conferences, at least I do. I don't know what you do with your
Life of the party you are, Stavros.
yeah. But I mean, so much of the presentations are cost effectiveness analyses of medications and therapies, and you come to the U.S., it's just like we spend too much money on healthcare, and it's just like it doesn't permeate our headspace. So it's just like careful what you wish for, because you might get it, right? Isn't that the kind of the
Mhm.
yeah.
I'm glad you brought up Pericles. Or I'm sorry. I'm glad you brought up Singapore.
Yes.
As you know, I've confessed my love for that country and their founder Lee Kuan Yew many times. Great
Yep.
book
Yeah.
from
Yeah.
third world to first. So uh,
Yeah.
Lee Kuan Yew, one of the three greatest statesmen ever. Pericles, George Washington, Lee Kuan Yew. If it were up to me, he'd be on Mount Rushmore. Uh, let's shift gears
Mhm.
and talk about what I've termed modern industrial diseases. They uh, diseases, diabetes, certain forms of cancer that hypertension that you almost don't see in the developing world, or at
Mhm.
best they're rare enough to be in a lot intellectual curiosa.
Mhm.
Uh, so is it a demon of our own design?
Yes. I got just one thing though. These diseases are in third world countries, so that's or whatever communism fell, whatever these countries are called now, or we're using older terms, I guess. But yeah, so I mean, I think you'd have to go all the way to um, Stone Age countries. So there's, I think so. I'll give you an example if you want. So there's like some tribes in South America, the Yanomamo and the Yakwana or something. And the researchers have gone in there, and let me back up a second. One of the characteristics of, say, hypertension is that hypertension prevalence increases with age. So as you get older in the United States, more and more people have hypertension. So, more people in their 30s than in their 20s, 40s in their 30s, and so on and so forth. So, by the time you're like 70s, it's kind of the most prevalent group. And, you have this kind of increasing prevalence with age in the United States. So researchers, looked at these tribes. They kind of have these ancestral ways of being. They live outside. They're kind of hunter gatherers, whatever they do, and they track their blood pressure by age group. And what they found was that their blood pressures were stable. There was no difference by age. So hypertension is elevated blood pressure. So what you could see is that if you live this ancestral life, you'll have the chances of having blood pressure are very very small, or having hypertension are very very small to non-existence. And these people live in the same world as us now. They're down in somewhere in South America and some.
So we can't attribute it to the ozone layer. It's not something that affects all of us. The
Yeah,
whatever
I'm
the
sure it was. Yeah, it didn't get them.
Yeah, so whatever the origins of hypertension are in the Western world, it's not a common factor that's common to the globe.
Right, right. But it's the to the so India has large hypertension problems, diabetes problems. Like their diet is not, it's very carb heavy, low protein. One of the few countries that has kind of low protein, systemically low protein consumption. Because I don't know, the vegetarianism or whatever the reason is, but high blood pressure is very common there, diabetes. So it's even just getting a taste of the Western, or I don't know, Western modern, whatever you want to call this system we have now. Just even getting on that path is enough to start us on
Y-
this.
You used a term for that, the tendency of blood pressure to increase with age. You used a term for that in our previous discussion. What's that?
Uh, uh, what-
Something like essential hypertension?
Oh yeah. So blood pressure, that's the best part about it too. So when you have the ICD code, right, for blood pressure, it's essential hypertension. It's of the essence. It's just like they're not, entirely sure like what, I mean, they do know what's going on, but it's, increased pressure on your blood vessels, but it's just like what is driving that essential pressure. It's just kind of, it just happens, right? And it's sort of funny to read. I'm not a doctor. I'm an economist by background. I count things, as we talked about. So I just find it funny when I read this stuff, and I'm just like, what do you mean it's essential hypertension? Like it's just
It's
pressure.
just, it's just conjured out of
It
the
just,
ether.
it just
Essential
happens. It's what's funny is that you could, drop blood pressure, fairly quickly, fairly easily. So it's just, and you have your blood pressure sitting down, laying down, sitting up, standing up. These are all your blood pressure varies widely throughout the day, depending on what you're doing.
Well, that's reassuring. So the guys who are getting it checked once every 6 months at the doctor, if that, 'cause we might not be there might be some volatility in that time series,
So yeah,
like
yeah.
as we like to say in economics.
Yeah, that's
The,
kind of
the
sorry, good.
it, the viewers at home. So I'm a big data nerd, so I'm familiar with the ICD codes. But would you like to touch on that for a second? What those mean?
Oh, sure. So ICD codes are the International Classification of Disease. They're on version 10. And what they're set up to do is describe every medical condition. So, there's an ICD code for type 2 diabetes, type 1 diabetes. There's an essential hypertension, elevated cholesterol, whatever types of cancer there are. There's ICD codes for anything and everything. And, one of the main purposes of that is to, um, at a medical visit, we've kind of changed medical visits over time. And, a lot of people haven't realized that we've really increased the workload on physicians, because not only, do physicians have to provide the medical care that they've always provided, but now they have to provide this information bundle to their electronic health record. So they have to document all of the things that have happened in that visit. And, this is one of the things that, needs to happen for a medical professional to get paid is, what was the reason for this visit? And you have to type in all of the medical codes that, are relevant to this patient, anywhere from, cold to whatever.
Reason I brought that up is one of the happy consequences of that is we have a treasure trove of data. Right? Basically, every reason that every person in in the contiguous the contiguous non-contiguous United States, every person who died, we've got a code.
Mhm.
When there was the incident with George Floyd and police killings in
Uh-huh.
2020, when that was a huge deal, I because I was at home with COVID for the lockdowns and had a bunch of free time, I found there was actually a ICD code for police killings, not surprisingly.
Okay. Yeah. The ICD-10 has been that was kind of one of the jokes. I don't know jokes, but like what are the things that there's like parrot attacks and like animal things that happen with animals, and that was kind of one of the you funny that you bring up COVID, right? I That was one of the things that with that whole COVID thing was that it was hard to track in the early days what was going on because there wasn't an ICD code for COVID until, something like March 20th of 2020. So there's like those weeks where it's just like, okay, this guy's in the hospital, he's coughing, but we don't know what it is. And even if we did know what it was, like, how can we document this to get this information to whoever it has to get to? And so this, communication issue really was highlighted that, and everyone freaked out. It's just like, oh, our system's falling apart. Well, the system's designed to work in a certain way, and all of a sudden you introduce this element that the system wasn't expecting, and it was a huge thing. Like you said, if there was a parrot attack, that we didn't have the parrot attack ICD code, um, the system would be okay, right? That's a rare, rare, rare thing. But COVID at the time, huge, global event, and those first few days, there's just not a way to kind of communicate well, which I think it still would have played out the way it played out, but it was difficult at the moment.
So you have to remind me before we wrap up. I'm going to ask Chat GPT what the ICD code for parrot attacks is and how many there were. So to put a bow on this topic, to paraphrase James Carville, in terms of the neologism, Andyism that I coined, modern industrial diseases or MIDS.
Mhm.
It's the lifestyle, stupid.
Yeah, There's just the way we eat, the way we live, the way we sleep, just all of it. It's just it's
Uh,
unclear which particular part of that is most important. If it all works together, I don't know, but it's all there. Yeah.
so essential hypertension is essentially a demon of our own design.
Yeah, I mean, you could, not everybody gets it. You're right. It's not like it's guaranteed that you'll get it. It's, the so-called silent killer. So a lot of people don't even know they have it. But you can, one of the things we looked at, we never published it, was the Medicare population. So Medicare is the old age insurance in the US, 65 and older. You could look at total spending uh, for the beneficiaries. And, if the population that has hypertension, their spending is, I don't know, however much it is, like $9,000-$10,000 a year plus on average. For those who don't have hypertension, their annual spending was something like $1,000-$2,000 a year. So it's just like if you live your life in such a way that you're able to get to your old age without having developed hypertension, or um, you've done things well enough that your body and your healthcare spending is so low, your body is so healthy and your healthcare spending is so low that you're not, um, you're fundamentally different than the people who do develop hypertension in some way. That
Okay.
shows up and spend it at least. And if you had more a richer data set, it'd be interesting to see what other characteristics they have that those who never develop hypertension at those ages compared to those who do.
So there is an X factor that is contributing to that outcome, whether or not people get. Um, we all live in the modern industrial world, but there's that X factor. Some people are developing hypertension, and some people aren't.
You can dodge it somehow. I don't know what it is, but yeah, you could.
Well, that's why you're going to find out how we dodge it. That's why you're. That, that's why you make the big bucks.
Sure. I mean, it's right. It's no one wants to hear it. It's diet and exercise, go to sleep.
So, so kind of riffing on that
Nothing
topic.
fancy. I don't know.
Uh, uh, so we beat the hypertension horse to death and sent it to the glue factory. Another another mid modern industrial disease, obesity,
Hmm.
uh, big in the news for
Hmm.
for the advent of a GLP-1 agonist. It's
Hmm.
nothing else. Uh, So yeah, let's shift gears, talk about that, and maybe the easier. I've got two questions for you. We'll start with the potentially easier one. Adiposity, however you want to, whatever you want to call it, adiposity, being overweight, being overfat, having too much body fat. How big an impact does that have on health outcomes?
No, that's I think that's very important. It's a big driver of health outcomes. I mean, it's but sorry to get back to hypertension, but as you lose weight, your blood pressure comes down. As you lose weight, you could control your diabetes. So the GLP-1s, one of the things that they're seeing is that if you're pre-diabetic, tirzepatide, one of those newer GLP-1s, Manjaro or Zepbound, if you take those medications, you don't develop diabetes. And those medications also have weight loss effects. There was the few years back, there was something called the National, it's still around, the National Diabetes Prevention Program, where, they train individuals on healthy lifestyles, coach them. One of the effects of the program was a 6% reduction in weight. And so it wasn't even like a huge amount of weight loss, but it prevented people who had prediabetes from transitioning to diabetes. So just weight by itself, per se, whatever, is a big contributor to these factors. So to these other risk factors. It's you kind of, if you could control the weight, some people have bad genetics on one dimension or another. Maybe you have elevated blood pressure or elevated diabetes just because of the genetic luck of the draw. But as you add on more and more adiposity, all of those kind of move in tandem. And it's um, there's I've talked about the story with BMI and weight. So there's a study in NHANES. The government goes through and uh, kind of so CDC. Do you want to talk about the NHANES story real quick?
Yeah, absolutely. Yes,
Sure.
that's fascinating because a lot of people don't know about that.
Sure. So yeah, so the CDC, Centers for Disease Control, has a standing data collection program. Excuse me, where they have something called the National Health and Nutrition Examination Survey. There's series of trailers that go around the country and do extensive medical examinations on randomly selected individuals who participate in the study. So the
It's
individuals
kind of
get
like
this.
the Google Earth vans, except for health data.
Yes. Yeah, yeah. So we kind of get like a good view of the health of the nation. And what's nice is that they'll go through this long statistical process to identify different characteristics, different individuals within certain geographic areas. Randomly select an individual, say, "Hey, do you want to participate in the study?" The individual says yes. You'll get this extensive medical examination. We'll do your height, we'll do your weight, we'll get, your blood work, we'll take your blood pressure, we'll do like a DEXA scan, kind of see, body fat, we'll do blood work, let us know what you eat in the last 2 days, and, produces this really rich data set that researchers could then use to analyze. And, so what's nice is that you have this nationally representative data set of people, and you have a BMI measure on there because they take your height and weight, and then they take your DEXA scan so they could see how much fat, adiposity you have on your body. And what
So
they
you're
found,
using the cool kid acronyms. Not everybody's privy
oh,
to them. So BMI,
oh, sorry, sir, it says, yeah, so BMI is just your body mass index. Is just your weight divided by your height with some mathematics in it. So it's a way to standardize uh, body measurement. So that just because someone's tall, they might have a higher weight. So to account for the added weight that comes with height, we'll take your weight and divide it by your height with some
Okay.
mathematic adjustment. So we're not saying that a 7 foot tall person who weighs 200 pounds is not the same thing as a 5 foot tall person who weighs 200 pounds, right? There's
Got
the mass is different. And a DEXA scan, I'm not sure, I'm not a scientist, I'm not a person, but they're able to, do some scanning to determine, based on body composition, how much fat you have on your adiposity, right? You have in your body. And they're able to correlate those two. And they found that about 98% of the people who have an elevated BMI also have an elevated DEXA scan. They show up with a lot of extra fat on their body. So a lot of people say, oh, the BMI doesn't apply to me. I'm just, I'm an athlete.
So what?
I work out a lot. And it's like, well, unless you're like, able to walk on to like a D1, program or something, it's the added weight is really fat. But yeah,
So Cartman from South Park has claimed that I'm just big bone doesn't hold water.
yeah, the kind of outside of like 2% of the people who, LeBron James and your D1 players equivalent. Yeah, that's not.
Well, for the record, Stavros, I think I'm at least overweight or obese by BMI, but 11.5% body fat by DEXA. So I'm a 2%er
I always knew you were an outlier.
in every sense of the word, good and bad.
No, it's but yeah.
So that
But anyway, yeah. So good.
so that's potentially the easier question. Adiposity, being overfat, is top of stream for all these other adverse outcomes. Again, kind of beat that horse to death and send it to the glue factory. Let's talk about the GLP-1 agonists.
Mhm.
I like to think I'm on top of this stuff, but until I spoke with you, I didn't know how deep the rabbit hole went. So just please tell us about the origins, the genesis of these
Oh,
drugs,
sure.
what the hell they even are.
So yeah, so GLP-1s have been around for years. The first ones were set up to, based on like Gila monster saliva. I don't know. There's some natural process that somebody figured out, and it suppresses appetite. And the first versions of these medications you had to take twice a day. You had to inject them. Very uncomfortable, bad side effects. But if you have diabetes, they're effective to help control A1C levels. That's kind of their blood sugar levels, your long-term blood sugar levels. So they did that, but they were like, no one wants to inject themselves twice a day, and whatever. So they did some sciencey stuff, and they got it down to once a day, which great, but small gains. And that then they were able to do some more sciencey stuff, and they were able to get it down to once a week. It's kind of where we're at now. There's a weekly injection. uh,
So Stavros is he's pulling punches. I think your exact words when we first talked are whatever the theoretical merits of a drug are. If you have to inject it into your eyeballs 3 times a day, the
yeah.
compliance is going to very rapidly decrease.
Yeah, you don't want to be. Yeah, it makes it worse. Where's the you don't want to have too onerous an injection regime there to take it. So yeah, but it's there are medications that you do inject in your eye, but yeah, not this one, thank goodness. But yeah, I don't know how that would have taken off. But so they were able to get it down. And what's nice with the newer generation, the semaglutide, which is your Ozempic and Wegovy, and your tirzepatide is your sorry, Zepbound and Manjaro. They're really effective. They really work. They really suppress appetite, and they are able to get people to lose weight. And they do that by making you not want to eat. And that's good and bad for some people because, like I said, I have a friend who took the medication, and he didn't like it because he is diabetic, and he was just like, I don't want to eat anything. I find this uncomfortable. So this is the main effect, but for him was a side effect that he didn't like, that he just wanted to be able to eat food. So even though these medications have a lot of promise and potential, and are effective in the people that take them, they have to take them. There's other side effects, too. Gastrointestinal side effects. There's some injection side effects. There's some things that people may not want or may not enjoy using these medications for a long period of time. But when you look at the clinical trials, right, they demonstrate this, 15-20% decrease in weight, but that's over a year and a half time span. So these things aren't quick. They work, but you're going to have to be injecting yourself once a week for the foreseeable future to get these benefits. And they're hideously expensive. So, about $1,000 a month right now with insurance. The manufacturers are starting to get direct to consumer vials for like $500 a month. I joke with people, the cartels are going to drop fentanyl and, pick up Ozempic because you could get it for like $100 in Mexico for a month. So you have this huge price differential between different countries for these medications. So um, it's a really interesting space from an economics perspective because yeah, they work, but you have to take them indefinitely, and they're really, really expensive in the United States, but they're not as expensive in other countries because they're small molecules. It's regular chemistry. It's not like you have to some milk get the blood out of a horseshoe crab and then do all these biological processes like some other medication. Like it's just chemistry and then an injection. So, the price is you could compress the price dramatically.
Okay. Well, lots of people are booking vacations to the Tijuana CVS as we speak.
I don't support or condone. People do what they got to do or do what they want to do. I'm just,
So let's kind of recap the discussion to this point. Adiposity, top of stream for several other adverse outcomes.
yeah,
The GLP-1 agonist, the administration is becoming, it sounds like, less onerous, but still getting injected once a week. Not everybody's idea of a good time.
yeah,
Expensive as hell,
yeah,
even though the price could theoretically come down substantially because as you mentioned, we're not having to collect and gently extract this drug from horseshoe crabs. I think your
yeah.
said exact words. So, bottom line, are the return on investment threshold, do the GLP-1 agonists, do they chin the bar in terms of health and outcomes for the price?
That's the million dollar.
You're giving me the
That
sour face again, Stavros. Don't play
that
poker.
that that's the million billion $100 billion question because what's the time frame for these medications? How long do people have to take them? Right, those are the costs. The other thing that I kind of didn't mention is that the dosages that people take these medications at in practice is somewhat less than the dosages that you had in clinical trials. So the effectiveness isn't as large as you'll see in clinical trials. So, say the clinical trial says, I don't know, 15-20% weight loss, people are doing less therapy. And, it's kind of dose dependent. The higher dose you take, the greater your average weight loss. So but people are taking lower dosages. So the total weight loss might only be like 7%, 10%. So it's not the benefit is somewhat smaller than what you see out of clinical
Now,
trials.
if I remember correctly, we don't need a dramatic weight loss in order to observe beneficial health outcomes. I
Right.
think you said earlier,
Yep.
even 6% would make great gains towards
Yep.
reducing adverse health outcomes and reducing costs.
Right. Right. That's where it becomes this big mathematical exercise because heart attacks and strokes are rare events to begin with, thank goodness, but they're very expensive events. So you'll decrease the probability of those rare events, but they're already rare to begin with. So it depends on how much what's that differential, right? How many extra heart attacks and strokes are you preventing? that because that becomes the benefit. And there's other healthcare costs that you could save as well. And these are so new, we don't know what those healthcare costs could be. I mean, we could substitute in other people who have lost weight and compare as a kind of synthetic cohort, kind of an estimate, a guesstimate based on other data, but adiposity affects so many things. It's hard to tell if it's a apples to apples comparison. So it's its own thing. The research hasn't been done, and the research needs to get done, and it's probably being done somewhere, because these are hugely expensive questions, right? If you open up right now for the Medicare population, they don't cover GLP-1s for obesity, right? Um, and there's discussion on whether or not they should, right? And that's because it's the population where most likely to have a heart attack or stroke, people over 65. It's a big population of people. Drugs are very, very expensive. But is the juice worth the squeeze, so to speak, the cost benefit? And, when people take them, are they taking them at the doses that we're seeing? Another thing, we kind of spoke about this one other time, was the characteristics of the people who take them. So, a BMI of 30 and above is considered obese, and a BMI of 40 and above is considered severe obesity. And about, what was the number? 66% of the population that's severely obese is female, and 33% is male. So severe obesity is more common in women than in men. When you look at the usage of these GLP-1s, something like 80% of all the therapy is being taken by women compared to 20% for men. So more than what you would expect based on their population, characteristics. Like, if they were using them at the same rates, you'd expect about 66% of the medication to be used by women, based on prevalence of severe obesity in women. But there's some other thing going on where women are more likely to use these medications than men. So that's a kind of some other thing that has to be figured out. Either women are more comfortable, taking medications. If you look at other obesity medications like phentermine, kind of before there was GLP-1s, there's speed. So it was very fun. Whatever it is, I'm not a doctor, I'm not a scientist, but it's speed. So women were more likely to use those. And again,
Methadone, dexedrine, if you're going down to the CVS pharmacy this weekend,
I don't know what this stuff
the
is.
Tijuana pharmacy.
Yeah, your Tijuana pharmacist probably knows what they are, and they'll help you out. Uh, don't do drugs, kids. Just stay away from drugs. But what does it say? Yeah, yeah. So is it just a prevalence issue that women are more likely to have this severe
Yeah, I
obesity?
think so.
Are they more likely to want to take these medications? What else is going on? Are they more tolerant of the side effects? These are all open questions. So even if the cost benefits there, again, kind of harkening back to our discussion about employee benefits, right? There's a group of people who just don't care. Just like, oh yeah, great.
Sorry,
I,
yeah, I'm
I like
glad.
ribs. Who cares?
Beef ribs, available in the men's section of the rib department. I'm glad you brought that up. That kind of harkens back to like you mentioned, the discussion on employee wellness programs, the smoking cessation programs. So GLP-1s, again, kind of beat that to death. Let's talk about other interventions for dealing with adiposity. 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 Uh, what are the prospects there for non-GLP-1 interventions and their potential for success?
Oh, I don't know. Those are, yeah, yeah, I mean, that's everything is going there. It seems like there's no other medications. Like there's the surgeries that there's I haven't heard of any new procedures on the market coming on soon.
So we're looking at basically, well, methadone, dexedrine at the Tijuana CVS, your GLP-1 agonist, gastric bypass surgeries, and those are basically the non-lifestyle intervention levers that
Yeah,
we have.
yeah, that's it. From like what, yeah, the medical system can help you with. You know, I can't think of much, at least that I've looked at.
So let's go
Sleep
back to
apnea, like, but
what's that?
sleep apnea is another thing that
Okay.
might be there, but it's more, the causality seems to run from people that have sleep apnea put on weight, untreated sleep apnea put on weight. And even when you treat your sleep apnea, it doesn't necessarily lead to weight loss, but it's still a good thing to treat if you have obstructive sleep apnea. But they're kind of thinking that if we could treat sleep apnea, that might there might be some weight effects. But I don't know if I've seen too much on that, because, like I said, the causality goes, if you're not getting good sleep, you're going to add on a lot of weight.
Let's go back to the life. Let's touch on lifestyle interventions for adiposity a little more, and go back to the NHANES data. What were we observing there for the success of potentially lifestyle modifications and interventions on obesity?
So yeah, so for obesity, and Haynes is not very good for obesity. They're good for hypertension. The NHANES studies. So if with NHANES they could track your hypertension status, and whether or not you're able to get your hypertension under control without any medication. So like most doctors say, lifestyle and medication. Okay,
Or,
I don't want to.
or if not NHANES, any other relevant data
Oh
on
yeah, yeah, yeah. There's
potential success for lifestyle
Oh
interventions?
yeah, yeah, yeah. So yeah, 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 yeah. So there's an EHR study that
In the HR is
electronic health record. So
okay.
going back to what we were talking about, your doctor recording all of this information about your visit. One of the things captured at the visit is your weight and your height, right? So they're able to get BMI data for individuals, and as you go to the doctor over time, there's a record for your BMI at your provider, and not only for you but for everybody else who sees that provider, and there's an EHR record. So you could take those records, anonymize them, and give them to health services researchers like me. So but I didn't do the study, other groups did it, and what they were able to do was track population of something like 1 million plus people that had overweight or obesity. And they wanted to take out anybody who had medical interventions, like you said, gastric bypass, GLP-1s, any other medications to treat their obesity. And they said, okay, so this population, uh, what is that does not have any medical interventions? What is the chance, the probability that they will be able to get their obesity down to their BMI down to a normal BMI? So they're overweight, they're obese, they're severely obese, whatever the case might be. What is the likelihood that they could get it down to a normal BMI? And what they found was that only 5% of the people were able to get it down to a normal BMI. So 1 out of 20 people only 1 out of 20 people were able to get back to a normal BMI once they were obese without any medical intervention.
And the reason I found that so fascinating was that was a similar metric for hypertension.
Yeah, right. So that's the NHANES study that we had
Okay.
talked about once
So
before. Yeah,
so that's fascinating.
yeah.
We've got two different MIDS, modern industrial diseases, hypertension and obesity. We've got two different data sets, NHANES, and what's the other one? Electronic
It,
data records.
electronic health records. Just so
Electronic health records.
yeah,
Uh, so two different mids, two different data sets, and they came up with a similar number, a similar percentage of people for whom the lifestyle interventions was effective. We'll call it 5% ish.
yeah, yeah.
So that
It's mhm.
so is there a common X factor, the behavioral genetic the behavioral X factor that's driving them both?
I don't know. Access to Tijuana pharmacies. No, I'm just joking. I don't know. I don't know. Uh,
Well,
it's yeah.
well,
So I mean,
we can see if that 5% is concentrated in San Diego.
San Diego. Yeah, what's going on? I don't know. No, I doubt that. But there's like you said, so like we said, we were talking before too with the different populations, right? So you have a stream of people who are able to get through old age without developing any of these diseases, right? And that's whatever percentage that is. It's not large. I mean, it's large. It's 20%, 30% probably. I don't know. Hypertension. It doesn't develop, say hypertension. To me, hypertension is like how they say, whatever is the gateway drug to whatever. To me, hypertension is the gateway drug to, all these other things. Because if you, it just, or BMI, either one of those, but BMI is so, you could have a higher BMI and it doesn't show up, but hypertension that'll just change. Anyway, so to me, hypertension is kind of the gateway drug, not gateway drug, but gateway condition to all these other problems. Because if you get your hypertension under control, all these other things without medication, all these other things will happen simultaneously, I feel, for most people. But yeah, so you have this population that can keep things healthy their whole life. And then for everybody else, only 5% of them can change the course of their health through without medical intervention, which is kind of hard, but kind of you know you, it's indicative of how big of a change you'd have to make, because as you I think you called it well, like these modern industrial diseases, right? You can't live a life that most people live, right? Just you've defined it in such a way that, like, if you live in our society, you're going to get this. And I don't know if you defined it that way, but it seems like if you live in our society, this is what you'll get. And you really have to change the way you live to avoid these conditions. And that's hard because the whole society is pushing you in one direction, and you kind of
Well,
have to go.
that kind of harkens back to our discussion about the structure of the modern healthcare industry is kind of path dependence. We built this societal infrastructure of processed foods and sedentary lifestyle, and it's kind of hard to extricate ourselves from this morass.
It's even worse. Like, I was reading some, Gallup, the survey company, they did surveys of how many hours of sleep do you get a night. And what was great was that they had a data point from 1942 or something. And people in 1942 were averaging like 7.5 hours of sleep a night. And, they have, today's, population is something like 6.2 hours of sleep a night. And, okay, fine, you have an older population somewhat, it's harder to sleep when you're older, fine. But I don't think it's that big of a change. But it's just like, in
Well, it's
19,
goddamn Netflix. So I'm old. I'm 46. I'm old enough to remember. If you had insomnia, all you had to watch was infomercials. So you're either like, screw this, I'll try to go back to bed. But now you've got Netflix, you've got your dumb phone, you've got yeah,
you could just,
infomercials aren't the only game in town anymore.
it's so, yeah, so it's not like food, sedentary behavior. There's
Netflix.
Netflix. There's, the other thing was that when you're looking at overnight work populations, right? It used to just be like, cops, nurses, power plant operators, pilots. Now we have this enormous infrastructure of logistics people, right? That 24-hour Amazon delivery, right? Somebody's driving that truck overnight to get you your, cheap thing from wherever it's produced, usually China, right? This cheap thing you wanted to buy that you definitely needed, right? There's just this enormous infrastructure of people who are working overnight, that shift work that didn't exist in the past. So
Well,
that's a whole nother thing that's going on, that, your sleep schedule screwed up. And like we said, if you have bad sleep, you're going to overeat. And there's a lot like I said, it's once you start pulling on that thread of like, what is it about our society? It's just it keeps going and going, and you're just like, oh wow, what about this thing now?
That's truly fascinating, Stavros. I remember harkening back to my days in the corporate world with these 24/7 databases. It used to be when everything was paper and pencil filing cabinets, you didn't have to have somebody on standby in case your electronic record systems went down and needed to be rebooted. The
Mhm.
the only thing that could have happened to those paper and pencil, files was a fire. You
Mhm. Oh
didn't
yeah, yeah, yeah.
you didn't need someone, you didn't need someone staying up all night and keeping the systems running. So, yes, a truly fascinating insight. In the time we have remaining, we wanna do the lightning round. Are you up
Mhm.
for it?
Sure. Yeah, yeah, let's
Eh,
go.
what's your favorite non-economics topic to nerd out about?
Oh man, I really enjoy machining and like kind of metalworking. I do none of this. I do none of this. I watch videos. I am just fascinated by this, adding material, taking material away, shaping metal. This is, the different characteristics of the metal is just, it, I could never do any of it. I'm just thankful and grateful somebody has the patience and the tolerance for that. So it's just great to just see them do all that work. So that's really exciting. Not exciting, but I enjoy that.
Yes, similarly, that's why I work with words and computers and numbers, which is, infinitely entertaining, but as far as skills that might be useful post-apocalypse, no, I'm gonna have trouble finding a job. What's your, must-have read, blog, or podcast?
Oh, I really enjoy the defense economics. Uh, there's a YouTuber called Perun, Perun. He puts out a once a week defense economics PowerPoint. On again topic I have no connection to, whatever. But different weapon systems, different countries, strategic characteristics and profiles, just the way things work, and it's just really fascinating just to get a glimpse onto another uh, area that I just again have no connection to.
And and last, what's your pet peeve myth or that you'd like to debunk or at minimum, you'd at least like to stop hearing about?
I don't know if it's a myth. I hate the term processed foods. Everything is processed. A process is a series of steps. So short of like, I don't know what, like an apple or something, like even that you got to take it off the tree. It's processed. So I prefer the term, concentrated or refined or something, because that seems to be more what they're trying to get at. But yeah, I hate the term, because then it's like it's not just processed, it's ultra processed, and then it's going to be super mega processed. Then who knows what's next. So I just don't like that we've gone down that path to
So
describe
that's my project. I'll come up with, a more descriptive classification taxonomy for processed food. So you gave me a good takeaway action item. And last, what's the our listeners' call to action? So they've learned all about these important topics. How do they stay abreast of developments in health economics?
Oh gosh, yeah, I don't know. It's so much out there. Like just the basics. Just do the. If you don't know where to start, just start with the basics. I think it's not. There's the American Heart Association has something called Life Simple 7. Just basic metrics that you could follow and track. It's not easy because of the world we live in, but if you're trying to just get an idea of where to go from a personal health standpoint, no one will do this. The National Health Expenditures Report from the CMS, Society for Medicare or Centers for Medicare and Medicaid Services, puts out an annual report on where all the healthcare dollars in the United States go. How much was spent on inpatient care, outpatient care, drugs, whatever, whatever, whatever. Just if people just wanted to get a feel for the scale of these things, I think that's very interesting. No one will do that. That's total nerd economic stuff.
You
Whatever.
you underestimate the motivation of our listeners, Stavros. Well, ladies and gentlemen, this has been truly fascinating. I'm very blessed to have you as a friend and a guest,
Yes.
Stavros. Thank you for taking the time to meet with us today.
Thank you so much, Andy. This is great. Thank you so much. I was honored.
Take care.
Thanks.